Cornwall's position in the far southwest of England makes it a magnet for tourists and surfers alike, with its stunning coastline and tales of shipwrecks and smugglers. We visited the town of St Ives on the north coast of Cornwall and the Stenick surgery. Here the team runs a same-day service, which has developed from the minor injuries provision set up originally. This now meets the needs of a variety of patients, ranging from new presentations to exacerbations of chronic conditions. We met nurse practitioner Leah Reynolds, practice nurse Gail Roxburgh, and nurse manager Karen Jenkin, all part of the team involved in the service. We started by asking Karen to describe the team's work.
We see patients with minor injuries,
so
the same as a casualty department, an emergency department would see. Those patients can come here, and because of our skills, we're able to see and treat those patients with the ability to refer on if we need to. We can see patients with minor and acute illnesses, exacerbations of chronic diseases, along with support and guidance and help from the duty doctor that works alongside us as well.
So each of you are doing the same. Do you differ in the service, or are you the same person essentially, just working different shifts or running the same clinic side by side, or do you each specialise in a particular area? Or
we have, as Gail suggested, Gail works as the respiratory nurse,
right,
but also does near enough the same as we do within the same day service. So we all have the same patient caseload, if you like,
right.
And then we use our skills within the day to pick, to see the most appropriate patients.
I think the main differences are that Karen and I come from an A&E background, and Gail and Liz come from a primary care. So they're specialist nurses in asthma, and Liz is in diabetes, and our background is minor injuries. So we work together as a team doing that.
Right. So how does that, or did you want to add to that, Karen?
It just complements it very well, really. So we all have skills that we work together.
So when you were employed, each of you, I presume, were you all here before the service started?
No. Gail and Liz were here before.
Right.
Leah and I were employed to actually work within the service, and I was employed to set the service up.
Right, okay. So Gail, your background is?
My background is ex-midwife,
right.
Also worked up country as a sister in charge of gynae, cardiac, and then moved down here into a practice nurse post, which I hadn't done before. Then did diplomas in asthma and COPD, so I do all the asthmatic and COPD patients in the surgery as well. Liz, my colleague, and I were asked to get involved in something called acute illness. I think 2008, Karen, was that?
Yeah.
Yeah, where it was a very basic trial to see if we could see people with coughs, colds, very basic things. It then was trialled with bringing, sort of more experienced nurse practitioners in to set up a minor injuries unit, which neither Liz nor I were qualified in. And since then we've sort of gelled together, and I think we bounce off each other. I know that if something is on the list that isn't my field of expertise, but I might be able to sort of triage, I can go to either Karen or Leah if we're working opposite, and they will sort of give me their best advice or lead or come in and sort of pick up on anything that I may or may not be doing, and I would hope that that works reciprocally with anything that maybe we may have a little bit more experience in.
So are any of you nurse prescribers?
Yes.
Yes.
Are all of you nurse prescribers? Is that something recent?
It is for me, yeah. It was recent when I joined this post, because before that it caused quite a few operational problems, and it's much better for us to be autonomous, to be able to prescribe, obviously in the field that we're comfortable with and we've got the knowledge to do so.
So I mean, down here in Cornwall you're a bit cut off transport wise, etc. Where did you go and how did you find it?
Plymouth University.
Oh, right.
Yeah. So that's where I did my prescribing quite recently.
Yeah, right. Good experience?
Yes, it was a good experience, but I think the learning really has taken place obviously when you start prescribing. That's when I felt I really started to learn.
Right, so you work within, I mean, how does the practice operationalise that? I mean, you have the right legally to prescribe anything.
Yes.
But often you find that people work obviously within their scope, but there are restrictions. Do you prescribe on a day-to-day basis all sorts of things, or?
Yeah, we prescribe within our parameters, and it's very
Yeah.
important not to prescribe outside our parameters, because obviously, you know, we can head into trouble. So if we see a patient that we know what the problem is and we know they need a particular prescription, we'll go and talk to the duty doc and explain, you know, the type of patient we've got, and if necessary they'll come and see and say, yes, that's an appropriate medication to prescribe. So if we are prescribing, you know, it's slightly outside our parameters, we've always got somebody that we will talk to first before we do that.
There is a patient case that we can prescribe safely for, and certainly, you know, that's our job. That's what we do on a daily basis. So be more than happy within a certain parameters of minor injury and acute illness to do that. But certainly, if it comes to the contraceptive pill and things like that, then we would seek advice, obviously, from the duty doctors.
Yeah, we certainly don't prescribe cardiac drugs or anything like that. It's always within, you know, our scope of practice. Yeah.
I mean, that lends itself to the multidisciplinary team, really. I mean, you're almost implying it works because you all get on well, and you know. But I mean, has it been plain sailing? What's their attitude to increasing nurse autonomy, really, or nurse-led practice? Are they happy? And how do you negotiate the? You're smiling.
I think they love us. I think the GPs love us, actually. I think we're all quite sort of proficient at what we do. We've all got additional degree level courses. I mean, I've certainly done the advanced assessment and the minor illness and other things. So we have all got the experience, and I think with the GPs as well, they've got experience in different fields, so we bounce off of each other very nicely. And with Gail and Liz, it is very much a team effort, and we're all very aware of our parameters and you know, what we know and what we don't know, and know when to stop and then go and get somebody else, so that we're continually in and out of each other's rooms and asking and getting other people to sort of, you know, guide us through particularly difficult patients or problem patients, or patients, you know, that we haven't seen that type of presentation before.
So that kind of nurse-led clinics are slightly misleading because it's nurse-led stroke team-led, really.
And I think team-led is where we'd like to see it, really. I mean, it is nurse-led, yes, but we focus hopefully much more on the team and the involvement of the duty doctors, and as Leah points out, other doctors and other nurses with specialties in the practice that we can utilise. So from that point of view, I think it works very, very well.
I mean, how do you maintain your competence? Obviously, there's that informal. If you're a good team, you're sharing information and probably, I would imagine, pointing out when perhaps somebody needs to update on something, or you know, is there a myriad of ways that you're ensuring? Because you talked, Leah, about we don't step outside our parameters. I wondered how you knew that and what you did about it.
Well, I do 1 day a week still in the A&E environment, and I keep up to date, any new techniques and procedures. I think that's quite important, so I still have that link. But apart from that, we continually studying. I'm about to embark on the mentoring course at Plymouth University degree level, so we're constantly looking at new qualifications and moving that forward that way. But we also have magazines and things like Emergency Nurse, and websites that we constantly access to keep ourselves up to date. In terms of nurse prescribing, we're in constant email contact with the lead prescriber, who will keep us up to date on any new changes and so forth that way.
Can you explain for people around the world what the lead prescriber is?
The lead prescriber is a pharmacist for this surgery, who takes part in the nurse prescribing, and is just goes to any sort of meetings and conferences on certain medications.
Yeah, and we get sent monthly newsletters, which goes out to all the prescribers. So the nurse prescribers are on that email list. So we can keep up to date with the check. I mean, some of the things don't affect us, but it's useful to know. But there's a lot of things that obviously would. The other ways that we keep up to date, we have access to the websites all the time, so we use the NICE guidelines regularly and daily. CKS, Clinical Knowledge Summaries. I know it's recently changed its name, but that's the one that we use, Patient UK. And we also have monthly teaching sessions with our lead GP, and we do case-based discussions in the same way that the GP trainees would do, and we find that quite useful. So we bring obviously cases and discuss them as a group, or if there's anything particular that we would like to go through, then we can do that as well. And also on-the-job training and peer discussion. So if we have a patient that comes in that we're really not sure about, that we don't quite know what's going on, we'll get the duty doctor in and we'll actually go through it with the patient there, with the patient's consent, and learn on the job that we can will know what the management plan would be for that the next time. But we've always got that support there when we need it, and that's the important thing, and that helps us to grow, I think, as professionals.
I wondered about evaluation. You've changed and grown over the last couple of years. How do you know your patients aren't running out the door, or that they're very happy? I presume they're happy, and you know it. How do you know that?
They appear to be very happy. They actually come in asking to see the nurse, and the comments of that's a really good examination, or whatever. So they're very pleased to with that service. We also have a GP who does monthly audits of our work. And just looks at our standard, looks at our treatment, looks at the return rate of patients, and we've also done patient surveys in the past as well. We tend to leave that to the summer because that tends to be when we're the busiest, so we can have not just local input, but we can have the temporary resident and the holiday maker input as well into the service. And we do that over a month.
Yeah, because I suppose that's an interesting point to contextualise it. Who are the people coming? Because you're a big tourist county.
Very much so, yeah.
So is a lot of it not local people?
In the summer, no, because
Right.
we operate as a minor injury unit. So as any other minor injury unit in the county or country would have their local population as well as their holiday makers coming through, then we do that also. We also have patients that come in on holiday who's forgotten their medications or become unwell with a chronic disease that we would see in the service on the day, and treat appropriately with a short management plan. And it's quite difficult sometimes with patients that have got complex medical problems, but we would do a short-term management plan before their review at home.
I was going to say, because people are coming from a distance,
Yes.
they're here for a week, you have to liaise with a lot of different colleagues around the country, or
Potentially, most
Yeah.
definitely. I mean, that's obviously when they're registered here, you would take the GP's details and phone number, and if need be, we can always phone the surgeries to find out and inform them of what's happened to the patients.
Any other issues that you think would be useful for anybody who's setting up a similar service? Perhaps tips, advice. It sounds all so easy.
I guess looking back on it, it probably hasn't always been easy, but we've just worked through it as a team. And I think that's the important thing to take away from it. You have to work as a team.
And it's a never-changing service, so I just think it's always moving and it's always changing, and I think there's an element of having to be aware of that and be prepared for that, so that you go with the flow. Like in the summer we have lots of injuries, in the winter we have lots of coughs and colds, so it's constantly changing.
And we're privileged because we do get, as Karen was saying, holiday makers coming in, but we get a whole melee of people. So we still see our old favourites that will come in because they've got a chest infection or whatever. So we've got such variance, it's never boring. It's stretching us to our outer limits, but it's also very good because it's giving us a huge scope on all the different patient conditions, from acute to chronic.
So just a final point, I suppose, are you adding any more nurses to the team? Is this it?
Well, we don't know what's going to happen in the future, really, and I guess as the manager, we want, I would like to future-proof us really for the future. That's too many futures, sorry, I have to take those out. But looking at the skills that we may need with the new GP commissioning and the new white papers that are coming out, and how GP and the primary care is going to change, then I just want us to be ready and be flexible to meet that change head on, really. And we're also looking at working more closely with the local ambulance service to see if we can prevent admissions, communicate the patients that we have much better, And you know, if they're working closely with a practice, they could maybe go and do some home visits. If that was inappropriate, the patients could come down here and be seen by the GP. So we could work much more closely together, maybe offer a service that, you know, we could actually go out to see the patients as well. But that would most definitely need, you know, a larger nursing or GP team to be able to do that. So we look at it as a same-day service, and that may be nursing, it may be paramedical, emergency care practitioner skills, as well as GP.
So when you pick somebody, you're looking for a particular nurse with particular qualities, and it's not just their skills, is it? It's somebody, I presume, who is enthusiastic, proactive, because, you know, no disrespect to nursing, but there's all sorts of different people, and all of you seem to be, you know, enthusiastic and signed up to it. You're not looking for somebody who's just going to plod along and sit back on the laurels. You're looking for somebody who's really going to take this forward rather than just tread water.
Proactive, positive, flexible would be my top three, I think, and team player most definitely.
Yeah. Okay, anything else you want to add?
No.
Okay. Karen?
I also work as an ECP for the ambulance service, so that's just how I keep myself up to date as well. So doing the pre-hospital work. So trying to link in that pre-hospital work with the surgery and how that ECP group could be useful. And
so ECP?
Emergency care practitioner.
Right.
So how that could benefit the patients within the local area, you know, the whole community really. And to prevent admissions for the future. So if there's other ways that we can look at keeping people out of hospital safely. We have a community matron that works with us here, and we could look at using her more constructively within our team to be able to provide that service. So hospital at home, I guess, to a point.
Yes. Okay, thank you all very much.
Thank you. Thank you.
The same-day service is run by a multidisciplinary team. Rupert Morrill is one of the medical practitioners involved in the service and reflects on the evolving nature of the healthcare team at the surgery.
The same-day team is made up of a number of members. Most of the time there are 2 nurses working in that team.
So they see the patient when they come in. They're the first point of contact.
That's correct.
Right.
They see the vast majority of the patients initially. In a few cases the GP will be the first person to see the patient. If it's deemed to be obvious from the triage that's taken place from the phone call that it's probably going to be best dealt with most effectively by a GP, it may be the GP who leads and sees the patient first. In other instances the nurse may do the initial consultation, do the observations, and where they feel a GP input is needed, they may ask the GP then to see the patient. The doctor working in the service is therefore overseeing the nurses in that team, offering them support and advice, and as we've mentioned, sometimes seeing patients who have initially been seen by one of the nurses. The doctor is also involved in triaging the visit requests. Right. So another aspect to his work or her work is dealing with requests from patients for urgent GP appointments. So there's an element of triage going on, and the doctor in the service is also the first point of contact for the other nurses working in the service, in the practice, for the community and district nurses, for the midwives, for our community matron, and for the Macmillan nurses, where they have queries with regard to our patients. They will initially go to the doctor in the same day service for advice and help, which means that they're in general not having to disturb the other GPs in the building who are in clinic. So we found that enables the rest of the GP clinics to run fairly uninterrupted, which we find is a far less stressful and more efficient way of running the practice.
Just to clarify, Macmillan nurses are palliative care cancer nurses.
That's right, yeah.
Yeah.
Our Macmillan nurses do a fantastic job of managing our palliative care patients in the community, and we work very closely with them, and we feel that it's very important that we're able to respond quickly, and the same day doctor is often very accessible and can give them an answer very quickly, rather than trying to get an answer from a GP who's in the midst of a 15 patient clinic and is running behind and is feeling under pressure. So we hope that we're offering a better service to support the health professionals that we work with in the community.
I mean, the role of the nurse has changed. I mean, you've got nurse prescribers here. Many of them are nurse prescribers, and doing things that you know, around the world is quite high level, as well as to people in the UK. You know, seeing the roles change. Isn't that a threat to you as a GP? I mean, don't you feel that they're taking your job away?
Well, there certainly has been a shift in the workload that our nursing team are taking on, and I think it is fair to say that they are now doing roles which traditionally the GP fulfilled. As a practice, we're happy with that. We feel it's very much that we're working as a team, and we're aiming to have the most appropriate person do all the tasks that we're required to carry out. Our nursing team are becoming more skilled, and as you say, are now, many of them are prescribers. They're also managing acute illness and the minor injuries, and we're happy to support their development. We feel very much that working as a team is the key here, and so that although they are working in areas which traditionally we were doing as GPs on our own, and we are still working with them, and the strength in the setup comes from that team working.
I mean, how do you, as a practice, see those roles developing? Have you now reached the point where people's roles are fairly well defined, or in 3, 4, 5 years' time, if we came in, would the nurses' roles have changed yet again in relation to yours? Is it an evolving thing?
It is certainly evolving, and as I speak now, there are new roles for the nurses being developed. They are developing new skills. So yes, it is a continuing evolution, and I think that will probably go on for years to come. And I think that has huge benefits for our patients, has benefits for us as GPs, allowing us to concentrate on what you might term the higher level aspects of our role, which are far more difficult to delegate on. So I think we're generally happy with that. There is of course an economic consideration, and I think the realities of the funding for healthcare in this country mean that we're expected to deliver more for less money. So I think the reality of it is that we have to look very closely at who's delivering care, and generally the doctor, the GP in our case, is the most expensive person in the system. So looking at ways of giving some of our role to other people means that hopefully we can maintain the quality service that we currently deliver to our patients here in St Ives. And I think the economics of it are one of the drivers.
So you don't see them as mini doctors? That's not something that particularly is or worries you, that these nurses are becoming you know? I suppose you've addressed that a little bit. It's about meeting the appropriate needs of the patient, and that your role is evolving itself, and they're taking on roles that you traditionally took on, but they're not becoming you.
We don't think that they're becoming us.
Yes. Okay.
We see that they are part of our team, and together we are delivering a service to our patients. We are continually taking on new roles as GPs. More and more work that traditionally has been done by the specialist in a hospital setting is being passed down to general practice, and as we take on those additional roles, many of which are working at a higher level than traditionally we have done in general practice, then I think we need to use our team and our resources to help us take on those new roles. I don't think we see the nurses as mini doctors. I think we have a lot of respect for them, and we're very impressed by what they have achieved, and they offer a fantastic level of care to our patients. They very much see that they are working within a team, and we work with them, and I think that that's probably the best way of delivering healthcare.
And that's a changing nursing role that you've grown up with as a GP. It's not so you've obviously not been a GP for years and years, but that's something that's just a part of your professional life. It's not something that suddenly developed for you, that nurses were suddenly taking on roles. But I'm just thinking of the fact that there are maybe GPs who've been doing it 30 years or so, and it stayed fairly static, and suddenly in the last 10-15 years nurses have suddenly become prescribers but that's something that was just a natural part of your professional life anyway, because
yes.
You haven't been a GP for decades.
No, I think that's correct. I think it's something which I've always been aware of, and I think working in a very progressive practice where there has always been a lot of evolution and a willingness to change and try new things has meant that that's just taken as normal for me. And I think that's a very positive thing, and I don't feel that it's not alien to me in any way.
Okay, thank you very much.
Is that all right?
Yes.
Okay, I hope there's something sensible in there.